Thank you and good morning. I'm glad to be a part of this workshop, which is addressing something that I think is very important and increasingly something I have to think about in my different roles. So let me start by telling you a little bit about the background from which I'm coming to this. I've been a clinical nephrologist for about 30 years, mostly working in the area of kidney transplantation, not so much dialysis. I've been involved as an investigator in a number of trials in chronic kidney disease and even more so in kidney transplant immunosuppression. And then finally, for about the last 12 or 13 years, I've been an IRB chairperson and devoted a large fraction of my time to the oversight of research involving human subjects. And it's in that latter capacity that the things we've been talking about yesterday and today are increasingly being stuck under my nose, at least my IRB nose. So I'm going to start with a proposition, one that I certainly view as rebuttable and one that I will proceed to partially rebut myself, and that is that the risks of a standard of care intervention are the same whether the intervention is employed in clinical care or standard of care research. And when I first started to think about this simplistically and briefly, it seems like that should be obvious. Why should the risks, either in terms of their nature or magnitude, frequency, be different whether you're randomized to get that in a trial or you get it because you choose a certain physician? And furthermore, a corollary is I think if something is considered to be within the standard of care, the risks ought to be well known or at least better known than of really novel investigational things, even though we know sometimes things do pop up after many years of exposure, as with our non-steroidal anti-inflammatory drugs. Well, one limitation that came to my mind about my proposition is that it's only true if the interventions are applied precisely the same in the research study as in clinical practice. And I can think of some reasons, which I'll go over, why that might, at least in some cases, not be true. For example, if we have a study which compares things within a believable standard of care where the therapy is targeted to a continuous physiologic variable, such as arterial oxygen saturation, that happened in a study we're skirting around a bit. I'm going to call it the Voldemort study, but for you Harry Potter fans out there. And so you might be more likely to be targeted to a very low or high end of this range. And people have discussed that aspect of that possible risk of randomization yesterday as well. Another one, maybe this is a little overly imaginative, but perhaps in a randomized trial, providers might in some cases be asked to use or supervise a standard of care alternative that they're not as familiar with or maybe not as skillful at doing. And of course, we doctors don't like to admit that that could happen. I suppose this would be more likely in a trial that was comparing actual procedures or something procedural or surgical versus medical. Another possibility is you might conceive of the fact that in some research that would compare usual clinical care scenarios, things might be added on that could change the risk or increase the risk. And the thing that popped into my mind there is genetic testing. You know, it seems like that's being added on to an ever-increasing fraction of the trials that we review, and I wouldn't be that surprised to see that coming into this area of research either. And we're not here to talk about the risks of genetic testing, but if it's done for research purposes, I think that has to be considered. Maybe the one that I find the most compelling or the most worthy of thought is the loss of patient or subject choice about the treatment that they're going to get, and therefore the side effect profile to which they might be exposed. And I guess that would be most clearly evident in a trial that compared surgical to medical therapy, but it could happen in comparisons of medical treatments as well. Well, what is one common risk, I think all too common risk, of standard of care, usual care treatment in the clinical setting? Well, I think it's the very real risk that you might receive treatment which is ineffective, unnecessary, expensive, and maybe even dangerous. And unfortunately, though, I think most of you agree that that's true. That is not immediately lessened for the subject in front of you by having them go into a study that randomizes them to different alternatives with perhaps somewhat unknown outcomes. And by way of illustration, I'm going to talk briefly about something called the CAST trial, the cardiac arrhythmia suppression trial. This was actually called to my attention by my wife, who's a pediatric cardiologist, but this was a trial that was carried out in the 1980s to look at 3 different drugs given to patients after a myocardial infarction or heart attack to suppress ventricular ectopy. So the rationale or logic goes like this. After a heart attack, a lot of patients will have extra premature cardiac beats coming from an abnormal area in the heart. If those fall at the wrong point in the cardiac cycle, it can trigger ventricular tachycardia, ventricular fibrillation, and perhaps sudden death. And we thought back when I was a resident, we knew that that happened. We knew that certain antiarrhythmic drugs could at least reduce some of that ectopy, those premature beats. And so it seemed like unassailable logic that giving people those drugs after a heart attack would be a good thing to do. And 2 of the drugs used in this trial were marketed, and I think can be very reasonably said to have been within the standard of care at that time. So much so that some people argued that the inclusion of a placebo arm in this trial was unethical. And there was a placebo arm. Well, the result, I hadn't really looked at this before, the result I think was kind of shocking. And the relative risk of death for people getting the 2 marketed drugs was 3.6 versus placebo, and that was very highly statistically significant and clinically significant. And in fact, it was significant enough that the DSMB for this study stopped the trial at about 10 months, at least for those 2 arms getting the marketed drugs. Interestingly, the investigational drug was not as bad as the marketed drugs. And so I will leave it at that. But that, you know, I'm sort of, what does that tell us? Well, I'm kind of preaching to the choir on that issue. I think there's pretty good agreement that we know that a lot of things we think today are good to do are going to turn out to be not so good. If we're focusing on the issue of communicating with research subjects, I guess this fact is a little less useful. It's true we can use it as an explanation of why we need to do this kind of research, and we should, but if you were going to enter the CAST trial back in the 1980s, it was not going to help you that much in terms of understanding your risks because they were not really known until the end of the trial. Another way of thinking about a difference between standard of care research versus clinical care would be something that I decided to call the increased spectrum of risk exposure that a person might get by entering a randomized trial of these interventions. So let's say treatment A has risk X, treatment B has risk Y, and in research with A versus B, I could be exposed, possibly exposed to the whole spectrum of these risks. And it's related to what I said earlier about the loss of choice issue, but it goes a bit beyond that. It also has to do with issues of individualization of therapy and preference or avoidance of one or another side effects. And the example that came to my mind in the area of my own clinical work, today compared to 15 or 20 years ago, we have a much broader spectrum of available drugs to keep you from rejecting your transplanted kidney. And they have very differing side effects. And one of them causes a lot of excess hair growth, which is especially troubling in women and children. So if we did a trial that was comparing that drug to others, you would have a greater chance of having to accept that side effect. Now, you could deal with issues like that by subject selection, inclusion, exclusion criteria, but then you get into introducing bias and limiting the generalizability of what you learn. Another thing that I think it's debatable, and it's been debated already yesterday, as to whether this particular item is a risk of standard of care research. But you might be assigned to a group that does less well and get treatment that you wouldn't have gotten in clinical care. I guess we have to consider that possibility. If we're not studying something where one group is possibly going to do less well than the other, why are we studying it? I guess how much this matters, at least in my opinion, depends on what kind of outcome you're talking about. If you're doing a trial of treatment of hypertension or high cholesterol, the outcomes are likely to be heart attack, death, or stroke. And those are all bad things. Yes, so is an outcome always a risk? No, but I don't think it can be totally dissociated from being a risk. True, it is true, the underlying disease is basically responsible for the morbidity and mortality, but I think this has to at least be stated to patients as a possibility when they go into a randomized trial, and it's something that I certainly did in my own research experience in the past. Now, you know, in other kinds of studies, the outcomes may be much less serious things that don't have nearly that weight. And for example, if you're studying toenail fungus, maybe this isn't quite the issue. I think we should be considering not just risks and increased risks, but also lowered risks or benefits. What would be a benefit of getting your standard of care intervention in a research study? Well, you have to admit, you might be in the group that does better. You might have been in the CAST trial in the placebo group. You might, and this argument was mentioned yesterday, you might get better care in a research study. There's certainly evidence out there that that can happen. I always cringe a little bit when I start to make that argument, because you would think that maybe the answer to that is to do a better job of giving care routinely, but that isn't always possible. I think most of the benefit is probably to the future patients. The patients who went into the CAST trial provided us the benefit as physicians to know better what to do, and the patients today aren't hopefully getting the drugs that turned out to not be as beneficial as we thought. So in summary, I think standard of care or usual care treatments may have greater, or perhaps more importantly, not necessarily greater, but different risks in research and practice. And I certainly think that such research can be ethical and really needs to be done. But in general, the differences are enough, in many cases, if not all, to warrant consenting, or I would prefer maybe now to use the word informing subjects. Consenting kind of dredges up images of 20-page documents with a signature at the end, which I think is really not necessary in some of these trials. But I do think the issue of informing is important. So I wanted to go out and conclude with a couple of pithy quotes. So I sort of looked around and found a few. So here's one from a long time ago. "Be wary of the man who urges an action in which he himself incurs no risk." Now, does that mean I think all investigators need to suffer from the conditions they study? Well, good grief, I hope not, but it does mean that it behooves us at times to try as much as we can to take on the perspective of our patients and research subjects. Then I found another one that I thought was even better from a very unexpected source. If you don't risk anything, you risk even more. And I don't think Ms. Zhang was thinking about clinical research when she said this, but it struck me as being a good description of where we are. We and I think honestly our patients and subjects have to take on some additional risks sometimes to get beyond where we currently are, where the risks are substantial. Thank you.